Welcome everyone to today's webinar. Today's Saturday, March 27th, and I'm so very delighted to welcome our guest today, Professor Dominic Furniss from Oxford Lymphedema practice. I have known the professor for almost 2 years now. He previously spoke to our community back in the summer of 2019. Which seems like ages ago, given the pandemic. And before we get started, I just wanted to explain, as I was going down the registrants list, I didn't recognize a lot of names. So if you don't know what Lymphie Strong is a community that I started with my father in 2015. It was initially created to spread awareness about multi-generational primary lymphedema. My family has had lymphedema dyssynthiasis syndrome for over a century. There's 3 generations in my family. So my grandfather had it, my father had it, I've had it, and 4 other family members on my paternal side have had it. So I'm very passionate about lymphedema awareness, education. I know from firsthand experience how a person can go decades even before finding information. And with respect to surgery itself, I've never had lymphatic surgery, but in the early 90s, my late father went to a surgeon to ask if his lymphedema could be addressed from a surgical perspective, and they offered to amputate his leg. So I'm very, very passionate about spreading awareness when it comes to surgery and what those options may be. The information and the technology is continuously evolving and changing, and new methods are always being introduced. So without further ado, I'm excited to introduce the professor.
Thanks so much, Veronica. We were going to start with a presentation, hopefully for about maybe 30 minutes or so, where I'm just going to go through a bit about how I understand lymphedema from a surgical point of view, and what are the modern surgical treatments, not really amputation anymore, thankfully. So hopefully can you see my presentation okay? I'll look for a nod, hopefully, from Veronica.
Yes, it looks perfect.
All good. Okay. So what is lymphedema? What's the lymphatic system? So the lymphatic system is this series of interconnected tubes underneath the skin. And if we think about a leg or an arm, there's arteries taking blood in, veins taking blood away, and in between it flows through these capillaries, and some of the fluid from the blood leaks out of these capillaries, and it needs to get back into the blood system. And the way it does that is via the lymphatics. So the lymphatic capillaries suck up the fluid from the tissues, and then they pump it along. They've got muscles in their walls, so they pump it along a bit like your gut pumps your food along without you really thinking about it. And the fluid gets to these things called lymph nodes or lymph glands, and they're stuffed full of immune cells. So they're really good at catching bacteria and viruses and infections, and also catching cancer cells. And eventually, what you'll see here is that the fluid from the legs goes back into the circulation deep down inside the left side of the neck, and that's true for the left arm as well. And then for the right arm and right breast, it goes back in deep down on the right side of the neck. So lymphatic fluid has come from the circulatory system, and it goes back into the circulatory system. And here we have another video. These videos are just from YouTube, so they're easy to get hold of if you want them. And if I just pause it there, this gives us a bit more of a 3D view of what's going on with the lymphatic system. And I like to think of it a bit like a forest of trees. So those tiny little capillaries that we saw, they're like the branches of the trees that you can see at the top of the screen here. And the little twigs, the capillaries, they join together to form bigger and bigger branches. And eventually they come together and they go down the trunks of these trees and into, these are a bit like the rivers of the lymphatic system here. And just to give you an idea of size, these rivers, these lymphatic channels, they are about 0.5 millimeter or so in diameter. So you can imagine how absolutely microscopic these ones up here are. And the other thing to notice here is that they put the little pinch points, these little pinch points on, and you might have noticed them in the previous video as well. And what they're representing are little one-way valves. And what that means is that the fluid in the lymphatic system in a normal situation always goes in one direction. That changes when lymphedema happens, as we'll see a little bit later. So this is a lovely video to illustrate things. So here's the fluid going into those tiny little twigs, those little capillaries, and getting carried down. You'll see they've put the pinch points on to represent those one-way valves. And as we go inside, we'll see all the fluid is coming down in one direction and not going back in the other direction. So you heard Veronica talk about primary lymphedema, and primary lymphedema is where there's a problem with one of those normal parts of the lymphatic system. So either those lymphatic capillaries or those collectors, those long rivers, or indeed those lymph nodes that we saw on the first video. And essentially, all primary lymphedema can be categorized as a problem with one of those. In terms of secondary lymphedema, this is by far and away the most common form of lymphedema that we see in the developed world, in fact, worldwide. And that's usually caused by a surgeon or a radiotherapist or another kind of doctor doing something to a particular patient. And usually that would be treatment of lymph nodes for cancer that spread to those lymph nodes. So a necessary part of cancer treatment, which unfortunately has an effect of leading to lymphedema. And you can see here, this is a review paper taken from the Lancet Oncology, where they looked at the risk factors for developing lymphedema after treatment for breast cancer. And the biggest risk factors were having the lymph nodes in the armpit taken away, having a greater number of those lymph nodes taken away, and also having had a mastectomy, indicating maybe a more advanced tumor as well. The only other factor which was very significant was higher body mass index. So we definitely know there's an interaction between the lymphatic system and the fat that's in a limb. And we'll talk about that a little bit more later on. But certainly that was the other lifestyle factor which came along. So we all know that lymphedema is a slowly progressive condition in general. Certainly without treatment. And what's the reason behind that? Well, my colleague Makoto Mihara, who's a good friend from Japan, he published this paper back in 2012, where he looked at what happened to the lymphatics after having treatment for cancer and developing secondary lymphedema. What he found was that the normal lymphatic here on the left, it has an inner wall, then it has a central wall which is full of muscle cells. They're the things which contract and push the fluid along, and then it has a sort of outer layer of connective tissue. When you're in the early phase of lymphedema, the increased pressure inside those lymphatics causes them to dilate, so-called ectasis here. And what that means is that those little one-way valves that we saw, those pinch points, they get pushed apart. And now you can get lymphatic fluid flowing the wrong way down the channels. And it can actually flow all the way back up the trees that we saw and out of the end the wrong way, out of the end of the lymphatic capillaries. And that really is what lymphedema is. But the lymphatics themselves, they're living structures, and they don't like being stretched and put under pressure. So they respond by the muscle cells in the wall getting bigger, much the same as if I sent you to the gym to lift weights, your muscles would get bigger. Same happens in your lymphatics. And also they secrete collagen or scar tissue, and that's to sort of resist the stretching and stop themselves being stretched too much. And as you can see, as that process goes on and there's more and more pressure, the muscle cells get bigger and bigger, the scar tissue gets more and more, and the lymphatic wall thickens, and that delicate pumping mechanism, which used to be there, no longer works. So that's why we see a slow progression over time in lymphedema. And we can see that when we look at patients with different stages of lymphedema. So stage 0, very early stage lymphedema. This is even really before there's symptomatic swelling, but we know that there's dysfunction in the lymphatic system. Most people with that generally have normal lymphatics, as you can see bottom left here. So nice and shiny, translucent, little blood vessel on the surface, keeping the whole lymphatic alive. As you get into stage 1, that's where you get more of these swollen ectatic, ectasia type dilated lymphatics, as you can see in the second panel. Then as the lymphedema progresses to stage 2 and eventually stage 3, you can see there's more and more scar tissue being laid down in those lymphatics when we look at them down the operating microscope. And on the right there, you can imagine that that lymphatic is not really pumping very much fluid and fulfilling much of its normal function. And they categorize the lymphatics that they saw down the operating microscope in a series of patients with different stages of lymphedema. And you can see that the functioning types, the blue and the green, decrease as your lymphedema progresses to later and later stages. And what that implies is that we probably need different treatments for those different stages, certainly different surgical treatments for those different stages. One more slide about pathology, and what this illustrates, this is a section, a post-mortem section taken from someone who had lymphedema on one side of their arm, one arm, and not on the other arm. And what you can see here is that the size of the fat underneath the skin there is much bigger in the lymphodematous arm compared to the normal arm. And the reason for that is that the fluid in lymphedema contains proteins, and it contains growth factors and inflammatory factors, and they cause the fat inside, the normal fat inside the arm, to grow and get bigger. And that's nothing to do with putting weight on. It's a direct consequence of the lymphedema itself. And again, if you've got a lot of fatty overgrowth, that implies you might need a different kind of surgery to help with your lymphedema. Okay, what about investigations for lymphedema? Well, traditionally lymphoscintigraphy, which is in the top center here, was used, and the black arrowhead there shows an area of lymphedema. And you can see it's a grainy picture. This is 2 legs. It doesn't give very much anatomical detail, not very helpful when planning surgery. MR lymphography, so magnetic resonance imaging, MRI, is shown bottom left. This does give quite a lot of detail, but there are difficulties determining which of these vessels are actually lymph vessels compared to veins, and the exact anatomical location of them. So what we use in our practice is called Icg Lymphography. So here there's we inject a dye, a fluorescent dye, into the subcutaneous tissue, gets taken up by the lymphatics, and then we can image them live using the little handheld camera that you can see me holding here. And this is a really good way of mapping lymphatic function. So essentially what we're doing, if we think about the forest of trees from the video, we're injecting a bit of dye into that canopy. It's getting taken up by the lymphatics, by the little capillaries, passed down into those lymphatic channels, and then we see those as linear channels on the screen. If there's a blockage in that, what happens is it gets pumped along and then it hits the blockage, and because you have that dilatation happening, it can go the wrong way up the lymphatics and out into the skin, and we call that dermal backflow. And this pattern is reticular pattern of dermal backflow, and here it's going from the branch to branch to branch of the trees, sort of in the canopy of the trees, to try and get around the blockage. As it gets worse, even that mechanism for getting around the blockage by going from branch to branch to branch starts to fail, and you get pooling of the lymphedema fluid, which is marked by the dye, in these little spots, and we call that a starburst pattern. So here, if we go clockwise from top left, you can see normal linear lymphatic channels. Then you start to see some channels, but with some small patches of dermal backflow, and more extensive dermal backflow, starburst pattern. And then eventually, when the lymphatics completely fail, the dye doesn't get taken up into them anymore. It simply diffuses through the limb. So there, what you can see in that foot is an injection just at the base of the toes, and the dye just diffusing to up into the toes and along the back of the foot. So I'll show you what this looks like normally. So this is a normal arm, and you can see that delicate pumping mechanism pumping the dye along. There's no muscle action here. This is just at rest, and you can see that dye pumping along and moving. This is abnormal function. So here we can see some deep dermal channels, and then some dermal backflow, big patch of dermal backflow on the right, then some more normal channels, another patch of dermal backflow on the left. So as the dye's gone along, it's hit a blockage and come up and back and out into the skin. So this is early patchy dermal rerouting, dermal backflow. And here on this video, we'll see the dermal backflow actually appearing. So we're massaging some dye up in normal lymphatics, they're hitting a block, and it's coming up and out into the skin. So you can see that Icg Lymphography gives us really fantastic anatomical information about where the functioning lymphatics are, where the blockages are, where things are going wrong pathologically. And that really helps us when we're thinking about planning surgery. We've probably done close to 2,000 Icg lymphography investigations now, and we've learned quite a lot from that. We've learned that not everyone who thinks they have lymphedema actually has lymphedema. It's remarkable to say to patients who maybe have been wearing compression garments for 10 years or more, you're perfectly fine. You don't have to wear those garments anymore. We've found out that if you're going to do massage, you need to press quite hard to move the fluid through those lymphatic channels. If you do light stroking, which a lot of lymphedema therapists are taught to teach you, then that doesn't work. It doesn't move the fluid really at all. If you do deep breathing, if you massage your neck, if you do kinesiotaping, that has no effect on the lymphatics at all. So these mechanisms, these modes of treatment that are often recommended to patients, they don't actually change anything about the way the lymphedema is. It does show us some rerouting patterns, which are sometimes unusual, and these can be helpful for patients because they can guide them where to massage the fluid in order to get it round their particular blockage. Knowledge is definitely powerful. It enables the patients to make a sensible, informed decision. The patient often knows best, so very often they'll come to us and say, I've got some swelling just here, and that will be exactly where there's a patch of dermal backflow. And also we can detect abnormalities before the patient even knows that they have a problem, before they know that they have lymphedema. And that really has led to our screening program, whereby we take high-risk patients who've maybe had, let's say, their axillary lymph nodes taken out, and then maybe had some radiotherapy as well. They're at high risk for developing lymphedema, and we'll see them a couple of times a year for the first 3 years, which is the peak period for lymphedema onset, and we'll screen them by Icg lymphography. If it's normal, they're empowered to go out and carry on living a normal life, don't take precautions. If it's abnormal, they're empowered to make an informed decision about what kind of treatment they might wish. So finally, I'm going to get on to talking about surgical treatments, which is really what Veronica asked me here to do. But I think it's important to have that background to understand why surgical treatments are offered and why they're offered in particular situations. So the first of the modern surgical treatments I'm going to talk about is lymphovenous anastomosis, or LVA. And the idea here is that, let's say you have lymphedema in your arm, you have a blockage in the armpit, and the fluid in the arm is trying to get back into the circulation somewhere up in the neck. So it has to get past that blockage to get back into the circulation. So what we say with lymphovenous anastomosis is, well, why are we trying to force that fluid past that blockage? Why can't we put it directly back into the circulation in that arm or in that leg? And that really is what's illustrated here on the bottom right. You can see a vein, which is colored in blue, has been divided. A lymphatic that's colored in yellowy, greeny color has been divided. And the two have then been stitched together. So the lymphatic fluid can drain directly back into the veins. Now that's only going to work if that lymphatic is already has some decent function remaining. So it's already pumping some fluid. If that lymphatic has got to that stage, that end stage, that sclerotic stage, it's going to not be so effective, even if we can do a really great operation, a perfect operation. The advantages of LVA really are that it's very minimally invasive. We do it as a local anesthetic procedure, so no general anesthesia, a day case procedure. Usually we do 4 incisions. The incisions are about 2 or 3 centimeters, has a very low complication rate. But as you can imagine, if these tubes that we're stitching together are about 0.5 millimeter in diameter, it's very highly technical. So this video will just take you through a sort of typical case. Here's me mapping out the lymphatics pre-operatively. So this is what we see on the Icg scan. You can see me with my pen in hand there. The end of the pen is fluorescing. And I'm marking, or I'm demonstrating there where the lymphatics are, the straight line channels, where the blockage is, because we can see it's going up into an area of dermal backflow there. And that allows me to mark on the patient's skin exactly where I want to make my incisions to do LVA surgery. So I know that I'm going to go in and I'm going to find a functioning lymphatic there when I'm doing my operation. So here's the lady's arm marked up, ready for surgery. We inject blue dye in order to visualize the lymphatics, and I'll show you some pictures of those intraoperatively shortly. They're the type of joins that we can do, end-to-end joins or sleeve anastomoses. And this video gives us an operative demonstration of an LVA. It's actually being performed by Alex, my colleague. There you can see a lymphatic with some blue dye in it. That would be really hard to see without the blue dye. So that's why we use the blue dye to help us visualize them. And they're tiny. This one is actually, we'll measure it at the end, but it's actually about 0.6 of a millimeter in diameter. This is all done down the operating microscope, so we've got really good vision and really high magnification. So Alex has found a vein, he's found the lymphatic, he's divided them both, and now he's going to suture them together. So the lymphatic's on the left, the veins on the right. That tiny suture that he's using is about 1/5 the diameter of one of your hairs on your head. So it's absolutely minute. And there he is, passing the needle through both of them. Obviously this is speeded up. We don't quite work at this speed. I wish we could. And he'll go around and put around about 6 or 7 stitches in this particular join that he's making. And each one of them knotted individually. What you see now, he takes the clamp off the lymphatic and then does a bit of massage, and you'll see there's a blue coloration going to the right there where his forceps are now, and that shows the lymphatic fluid going across the anastomosis and into the venous system. So already the lymphedema for this patient is starting to drain directly into the lymphatic system. Here he is measuring it. It's around about 0.6 of a millimeter. And what you'll see now, quite convincingly, is the vein on the right-hand side has turned blue. And so that shows that that particular anastomosis is working beautifully. And then we stitch up the skin. So these are normal stitches in the skin, and you can see how much bigger they are compared to the ones that we use down the microscope. This is the patient's view. So there's both Alex and I operating on someone. This lady tweeted that picture during her operation. And these are the sort of typical things that we do. So a small lymphatic, a slightly bigger vein joined up with blue dye going across from right to left this time. We can do other things such as 3 lymphatics into one slightly bigger vein, and then another lymphatic stitched in what we call end to side onto that vein. So that's 4 lymphatics into one vein, really supercharging the drainage for this patient. Here's another quick video just showing the blue dye going across. And you can see there's the join, and in slow motion you'll see the blue dye coming up and across and into the vein. So that's lymphatic fluid going across that join and into the vein and helping drain the lymphedema for this patient. So who's suited for LVA? The lymphatics need to be working. So Icg will show us that. It will show us how far the dye goes. So if we inject the dye into someone's foot and it's only got to the ankle within half an hour, then those lymphatics are really not pumping well enough for LVA. If it's got all the way to the groin, fantastic. LVA is a possibility. Tends to be for earlier disease or moderate stage disease. It tends to be much more appropriate for secondary lymphedema compared to primary lymphedema, although there is one subtype of primary lymphedema where the problem is in the lymph nodes themselves, and they are particularly, those patients are particularly suitable for LVA, and we've seen some really good results on that. It's obviously an operation that will help move fluid. So if you've got to the stage where there's a lot of fatty lymphedema, then this is not such a good operation. And we don't so much rely on volume difference, because the aim is always to try and downstage the lymphedema and make things easier for the patient. So just to give you an example, this is a doctor who came to us for treatment, typical history of a mastectomy and lymph node clearance with swelling and heaviness in her arm, and she was wearing a compression sleeve and a glove 24 hours a day, which made it very difficult for her at work. She had multiple LVA surgery after assessment with Icg Lymphography, and you can see here there's some lymphatic channels and some areas of dermal backflow. And when we compare pre-op on the left to post-op on the right, we're looking at the right hand here, so the bottom of that figure, you can see that she's got all the definition back on the back of her hand. You can see her tendons, you can see her veins, and she's essentially got back to being pretty much completely normal. It doesn't always work for absolutely everyone. So you can see some patients in red here where the limb volume's gone up. In the top panel, these are people who start with a volume excess of less than 5%. So really small volume excess, maybe just in the region of 20 or 30 mils sometimes. And they have a sort of variable course. None of them get particularly worse. And importantly, you can see on the right-hand side, 6 out of 9 of these patients who we analysed, this is a few years ago now, who we analysed, so 2/3 of the patients managed to get out of their compression garments. If you've got slightly more of an excess volume, so between 5 and 20%, you do tend to get a reduction in the size of your limb, but maybe now only about 1/3 of patients get out of their compression garments. If you start off with more than 20% excess volume, then again you get a reduction in volume, but essentially no one is able to completely get rid of their compression garments. We see a consistent increase in quality of life after surgery. This is a specific lymphedema quality of life index, and we see that that improves. And we've published our results on both arms and legs, and these papers are freely available from our website. Next operation that we do is called liposuction, or sometimes it's called suction-assisted protein lipectomy. And the principle here is that we remove all of the tissue between the the skin, all of the excess fatty tissue between the skin and the deep fascia. And the deep fascia overlies all the important things in your limb. So for example, your muscles and your nerves and things. So it's done in a very safe area, a safe plane. It doesn't reconstruct the lymphatic system at all. So we accept that the lymphatics aren't working anymore and they aren't going to work anymore. And what we're doing is we're trying to treat the volume excess and get people back to having an arm or a leg which is of very similar shape and volume to the other side. It's a much bigger operation than LVA. It requires a general anesthetic, usually a 2 or 3 night stay, multiple outpatient visits throughout the first year, most importantly with our trained lymphedema practitioner who will be looking after garments and compression in that first year. Getting those absolutely right is key to this. And patients really have to commit to wearing their compression garments 24 hours a day, 7 days a week. We do say for the rest of their life, but some patients can get away with reducing that when they get out to a year. And essentially what we're doing is we're making about 10 or 15 very small incisions on the limb and we're hoovering out all of that fat. Post-op, there's a dressing change on day 2 where patients go into some custom fitted compression garments. And as I said, extensive support over the first 12 months to really get the compression optimized. There are some surgeons around the world who are combining this with vascularized lymph node transfer, which I'm about to give you a brief talk about, or LVA. And they are claiming that they can reduce the amount of garment use that patients need. I would say this is experimental, but we're certainly watching that space and some of our patients are keen for us to try that with them. So maybe in a couple of years, I'll be able to tell you what our experience with that is. So who's best suited for liposuction? Well, the lymphatics need to be no longer pumping, so it kind of doesn't matter that we're not reconstructing them. And the patient needs to have non-pitting edema, so no fluid. So that means that LVA or lymph node transfer is not going to be effective. So we need to, there's no chance to reconstruct them. So we just need to deal with the secondary problem. And I always say to my patients, there's no rush to do this. You can think about it and decide when to do it and come and find us when you're ready to have this done. It is a really good operation though, it really works well. So this is just an example of one of our patients, 69-year-old lady, typical history post-breast cancer treatment, really fatty excess. And you can see here her arm pre and post-op, so much better volume, much better shape. And if we compare her pre and post-op measurements, you can see in the top panel, her arm started off just over 40% bigger and has ended up actually a couple of percentage points smaller. Importantly, her quality of life has skyrocketed as well. So this is a really good operation for people who are late on in the course of their lymphedema disease. And we know that this is a long-standing operation. Again, Professor Brawson, who really popularized this technique, he's shown that as well. So final part of the talk, I realize I've hit 30 minutes, so hopefully this won't be too long and then we can get on to Q&A. Vascularized lymph node transfer. So the principle here is that you take some lymph nodes from an unaffected area of the body and you transplant them into the area that has lymphedema. We tend to use either the neck or inside the tummy, depending on whether we need 1 flap or 2 flaps. So if we're doing 2 separate legs, then we'll use inside the tummy because we can generate 2 lymph node transfers from one site, whereas in the neck we can only get 1 lymph node transfer from there. Again, it's quite a big operation. It takes most of the day. It's done under general anesthetic. There's a 2 to 3 day hospital stay afterwards. There are complications, as there are from having any big operation, and probably the most feared operation is getting lymphedema at the place where you take those lymph nodes. And that is the reason why we choose the neck and we choose inside the tummy, because it's extremely unlikely to generate lymphedema in the neck or in the head from taking it from the neck and certainly inside the tummy. You can't really get lymphedema inside the tummy. Some surgeons will take lymph nodes, say, from under the armpit or from the groin to transfer to the other place. We have decided not to do that because our patients are just so scared that they will get lymphedema somewhere else. Most of them just said no, they wouldn't accept that. So when do we choose lymph node transfer? So we choose it when we don't think the lymphatics are quite good enough for LVA, but there is still fluid in the limb. So this is a fluid problem rather than a fat problem, but they're not quite good enough for LVA, so they need something else on top of LVA. And actually some of our patients do come and particularly request lymph node transfer as well. Does it work? Well, again, there's good research that shows that it does work. So this is a randomized controlled trial of lymph node transfer post breast cancer treatment. And you can see in the panel on the right, the group who had lymph node transfer compared to the group who didn't scored much better in all of these domains. So volume, infection rate, pain, heaviness, functional score, etc. So there's definitely good evidence that it works. As long as you choose the right patients. So what's our algorithm? Generally in the early stages, we'll choose LVA. As things get worse, we will consider lymph node transfer, and then in the late stages of disease, liposuction is the most appropriate. And this depends on a holistic assessment of the patient, their history, examination findings, volume measurements, and importantly, as I'm sure you're all gathered, Icg Lymphography. We offer a service to people from all over the world, and if you can see the blue dots, you'll see obviously most of our patients come from the United Kingdom, but we've treated patients from Canada, the United States, Brazil, South Africa, Australia, New Zealand, the Middle East, North Africa, and so on, from most of Europe as well. We offer screening, LVA, lymph node transfer, liposuction, and importantly, access to a really good lymphedema therapist who really helps care for our patients and optimizes their results. So this is a team. These are our contact details. You can find us on the web at olp.surgery. You can email us or you can follow us on Twitter, Instagram, Facebook. I'm afraid I'm not very good with all of those social media channels. Kate, who's seen on front right here, is fantastic at running those and can answer your queries on there. So at that point, I am gonna stop sharing and we'll head for the Q&A.
Do you want to read the Q&A yourself, or do you want me to read it out to you?
Yeah, go for it. Let's make it a bit more interactive, Veronica.
I'm going to go ahead and open up the chat as well for general comments.
Great.
I just bounced between the two. And I also had an email that was sent to you just prior to the meeting, but I'll get to that at the end. First question is, as a primary patient, the biggest problem is the foot and toes. Would LVA help with that, or is that only going to help the leg?
So LVA certainly can help feet and toes. Yep, I've certainly seen it help feet and toes. The difficulty will be, what's the problem in the lymphatics that's caused the primary lymphedema? And so is it a problem with those lymphatic capillaries that are getting the fluid into the lymphatic system? Is it a problem with those lymphatic channels that are transporting it up the limb? Or is it a problem with the lymph nodes higher up the limb? If the problem is in those lymphatic capillaries, then none of the fluid is getting down into the lymph channels, which is where we do the LVA. So doing LVA in that situation is not going to help. And we'll know that because when we inject Icg, the Icg will just sit in the foot and it won't move anywhere, and it will just diffuse around. it won't get taken up into any lymphatics. If the problem is in the lymphatic channels, those 0.5 millimeter diameter rivers, if you like, then what will happen is it will get taken up into the capillaries, but then it won't go into the channels, and it will just get passed from capillary to capillary to capillary. So we'll see that sort of branching pattern that I showed you earlier, and we won't see any deep channels. And again, operating on the deep channels, if the problem is in the deep channels, is not going to work. And so the only type of primary lymphedema where LVA does work is where the problem is in those lymph nodes. And the only real way to determine that is to have an Icg scan.
See, the next question is, would you briefly discuss pediatric primary lymphedema and at what age surgical options become viable? Would exploring surgical options for pediatric patients be earlier the better to preserve lymph vessel function, and at what age? Thank you. For reference, our daughter is 4 years old and just recently diagnosed with primary lymphedema.
Yeah, so again, I would say that pretty much the same answer applies to children as I've just given for the previous question. So it really depends on what the pathological process is. I have certainly seen children, young children who have primary lymphedema where there is preserved lymphatic function and they're suitable for LVA surgery, for reconstructive surgery. And in that case, then yes, the earlier the better, because as you saw in my talk, there's a gradual progression of the pathology within the lymphatics, with the lymphatics getting slightly worse and slightly worse slowly over time. Now, of course, the way to really diagnose this would again be to have Icg lymphography, which involves an injection. And my experience of injecting 4-year-olds is generally quite a difficult thing to do. It depends. It depends somewhat on what sort of 4-year-old they are, and so on. It depends how the parents are and what their daughter is like, really. Very rarely, I have seen children have an anesthetic in order to have an investigation. And that could be something else to consider, but that would really need discussing in very careful detail with a surgeon before undertaking that, I would say. So as always, knowledge is power, and being able to get the scan and determine exactly what's going on with your daughter would be the most important thing.
I'm just going to throw in my own question here. Would it be prudent to have imaging done to establish a baseline at a certain age, and then if they're not ready, have it done later, say when they're 10 or 12?
So
or it's a case by case?
Yeah, almost a case-by-case basis. I think for primary lymphedema, probably if there is an opportunity, so if the scan were to show the potential for reconstructive surgery, I probably wouldn't wait, because it may be that age 10, 5 years time or whatever, those lymphatics have degenerated such that reconstructive surgery is no longer an option. Now, we do have some patients where they've got very early, these are usually secondary patients who got very early disease, and say we see them 6 months after they finish their cancer treatment, and they've got very patchy lymphedema. And they say to us, well, look, I've just had all of this treatment. I really don't want an operation. Why don't we keep an eye on it? And that is, again, a really good, sensible idea to come back in 6 months. Let's see how it's progressing. And there you have your baseline, and you can see how your lymphedema is progressing. And we certainly have patients who we do that for at the moment. I'm not so sure that that's the right thing in primary lymphedema.
Okay. Next question is, have you seen better results with secondary patients compared to primary?
Good question. Overall, I would say yes, but it's all about selecting the right patient. So We are extremely selective in our clinic. We offer surgery to about 1 in 3 patients who comes to our clinic, because we really need to see that those lymphatics are functioning and that we're going to be able to make a difference. I should say we offer reconstructive surgery to about 1 in 3 patients. With primary lymphedema, that figure is about 1 in 20. So maybe about 19 out of 20 patients have a problem with either those lymphatic capillaries or with the lymphatic channels and the function of the lymphatic channels. So only about 1 in 20 are suitable for LVA surgery. Even then, even being super selective and really trying to pick out the best candidates, we still find that the results are not quite as good. So for secondary lymphedema patients, we will say about 10 to 15% of them don't really see a benefit from surgery. For primary lymphedema patients, we probably say about 30% of them don't see a benefit from surgery, even of those very selected ones.
Gotcha. It's tough. The next person just wanted to say hello, Professor. The next question is, do you feel lymph vessel transfer is better, the same, or worse, or a worse alternative to lymph node transfer?
I think that's almost impossible to answer because there haven't been any comparative studies. Lymph vessel transfer is a technique that's popularized in Germany. They see some excellent results with that particular operation. So the principle of that is, let's say that there's a blockage in the armpit, they'll take a lymph vessel from the thigh and they will bypass that blockage in the armpit by joining the lymph vessel up down in the arm and then the lymph vessel up somewhere in the neck. That technique is difficult for other surgeons to actually achieve. So technically, many surgeons have found that to be, they haven't got the same results as the guys in Germany who started off doing it. So it's a bit less reproducible than vascularized lymph node transfer or indeed than LVA. It's also not suitable for quite a few patients. So for example, if patients have had a pelvic lymph node dissection, which is quite common after prostate cancer or certain forms of gynecological cancer, then you can't get above that with a lymph vessel transfer. So for those patients, what the surgeons in Germany recommend is to go and see someone to have LVA. So for those reasons, we haven't pursued lymph vessel transfer, and I can't tell you whether it's better or worse than lymph node transfer.
Fair enough. The next question is primary lymphedema only genetic or a result of vascular issues? Can an operation make your condition worse? Mine has pretty much been stable for 15 years, but would still love to get rid of swelling. I stopped wearing compression stockings early on, and should I be wearing them?
Oh, big questions. So mostly it is genetic, and it's not a sort of single gene disease. That obviously there are exceptions to that, you were talking about lymphedema distichiasis and earlier, and that's an exception to that. And there are some rare. You're laughing at my pronunciation, Veronica. I can see.
No, I'm smiling because I only found out recently, and I don't mean to interject on this person's question, but I only recently found out I had the genetic marker in 2016. So I lived most of my adult life not knowing that my eyelashes and my legs, my lymphedema, were connected.
Interesting.
So that's why I'm smiling, is it's
very
not
interesting.
so evident sometimes.
Yeah. So yeah, it is genetic, but mostly it's a combination of lots and lots of different genetic variants which all come together in one person. So rather than a single faulty gene that gets passed down the generations, it's often sporadic, but it's just by chance several of these variants have come together in one particular person.
And I agree with you, because in our community, every now and then I'll poll the group and ask them what kind of lymphedema, and many will say that they're the first in their family or they know no one else in
Yeah,
their
yeah.
that has it.
And equally for those people, the chance of passing it on to their children is not very high as well.
Right. Yeah. That's another topic that comes up.
Yeah, yeah. So I guess that's good news. In terms of, can it be related to the vascular system? Well, there are some associated problems with the vascular system because the lymphatic system develops embryonically from the venous system. And so, yes, it can be related as well. Can surgery make you worse? We don't really see that, but you know, there are the odd patient who gets worse after surgery, but is that progression of their disease or is it caused by the surgery? That's hard to know. Should you be wearing compression? Well, if you've not been wearing it for 15 years and haven't got worse, then I can't really see an indication to wear it. The lymphedema therapist will probably shout at me for saying that, but you know, you have to think as a patient and as an individual, if it doesn't seem to have been getting worse, then why would it suddenly get worse, and why would you wear your compression?
And worse is so relative because you can have an anatomically fine limb, but it could also be all fibrosis. So
Yeah,
looks can be deceiving as well.
Quite.
Okay. The next question is, do compression pumps move lymph fluid, and has that been demonstrated by using Icg Lymphography?
I can't think of a study that shows that off the top of my head, but definitely we know they do move fluid.
I know the answer to that question. A study was done by the team at UT Health here. I can never say her last name, so please forgive me. It's Eva, and the person that I know is Dr. Melissa Aldrich. And they've published from here in Texas the study of Icg imaging and how
with compression pumps. So
yes.
Yeah, they're definitely a form of therapy which does work. It does do what it says, unlike sort of light stroking and so on. Yeah.
I hosted her as a speaker. The only reason I know is I hosted her as a speaker.
Right.
So I watched the entire presentation.
Good.
The next question is, I have a rare form of CKD stage 4 and bilateral leg plus one arm lymphedema diagnosed by Professor Mortimer using scintigraphy at St. George's in 2016. He recommended liposuction, but unable to get this on the NHS. I am now 53 and it is now severely affecting my mobility and life in general. What are the costs involved in receiving treatment if I was a good candidate?
Great. So I'm aware that this is an international talk and many of you will not know what the NHS is. So this is the National Health Service in the UK. So this is free at the point of care healthcare in the UK, paid for by the government. Unfortunately, in almost every instance, it doesn't fund surgical treatment for lymphedema in the UK. So most people have to undertake private healthcare, hence the question about the cost. I can't really say the answer to this question because it totally depends on the clinical assessment and what is required in terms of surgery. So I think probably the answer to that question is it's best to get in touch with us. The email address is info@olp.surgery. That's probably the easiest way of getting in touch with us, and we can discuss personal circumstances and potentially arrange a clinic visit where we can answer those questions properly.
And we can put the email and the website in the chat.
Perfect.
At the end. The next question is, Dr. Furniss, thank you for your presentation. This was very informative. I am a lymphedema therapist. I'm wondering if you have a specific protocol for post-op.
So for LVA surgery and lymph node transfer surgery, what we say is first week after surgery, no compression at all, and just simple massage, pressing hard, going from the far end of the limb to the near end of the limb. So for an arm, that would be from the wrist up towards the shoulder. and trying to push fluid across the joins in the LVA or push fluid towards the lymph node transfer. Then after a week, we usually get our patients to go back into a light form of their compression. So most patients have got some old compression sleeves or compression stockings that have lost a bit of their elasticity and aren't so tight. And so they'll go into those for a week. Then if there are stitches to be removed, they're removed at 2 weeks. And from there, they get back into their normal compression. They would usually start, if they did MLD or something like that, they would usually start that around about 6 weeks once the skin wounds are nicely healed and strong. But we don't really change their non-surgical management because, you know, if we're seeing a difference, we want to see a difference that's from the surgery, not from changing and upgrading their non-surgical management.
So you don't require anything like double compression or?
No. Now,
Okay.
liposuction is totally different. So in liposuction, then the post-op therapy regime is very detailed and very intense because we're not reconstructing the lymphatic system. So we're not allowing more of the fluid out. So we've got to prevent it from accumulating in the first place. And that's done by very tight compression, flat knit compression. We'll often take the seams in to get even tighter compression, and we'll often double layer as well. And that's worn day and night, at least for the first year. Usually by the time we get out to a year post-op, we've got that sort of first 3 months, there's a lot of post-operative swelling. And we've got that all under control, and the patients are into a single garment, which they renew every 6 months.
Great answer. The next question is, if the cause of edema turns out not to be lymphedema, what does it commonly turn out to be? Oh, that's a great one.
Ah, that's a difficult one. Best to ask a physician, I think. So there are all sorts of different causes of edema, and that could be a venous problem, could be a heart problem, could be a kidney problem, could be a liver problem. They're probably the 4 most common scenarios that we see. The other thing that we do see is obesity related edema, and that's usually also related to immobility as well. So if you're sitting in a chair for 20 hours a day or something like that, your legs will definitely swell. And that would happen to me if I sat in a chair for 20 hours a day. It's a bit like going on a long haul flight. Everyone's ankles swell a bit on a long haul flight. So we do see that, but probably if there is a pathological thing underlying it, it's one of those 4. So vein, heart, liver, kidneys. Veronica, you're on mute.
I want to apologize. My husband is cooking lunch. So if you hear pots and pans in the background,
No problem.
So excuse me, forgive me all. I was misdiagnosed for almost 10 years. We think that I had it at puberty, but after I had my child, my swelling went out of control. Do you think at this time surgery could correct it or manage it?
Good question. So times of hormonal change for women are often when primary lymphedema presents. So commonly presents in the teenage years. It can commonly present as well after children. And if it has started in the teenage years, as the lady said, then it can be exacerbated by having children. I'll refer you back to my previous answers, but it's all about the Icg Lymphography scan and the clinical assessment as to whether surgery is appropriate and as to whether what form of surgery is appropriate. So probably the best plan is to see a surgeon who routinely performs Icg Lymphography and also is able to perform all of the 3 different surgical options so that every option is available to you. And they will be able to diagnose you and come up with a bespoke treatment plan.
I'm going to hop on over to the chat real quick. We have just a general comment. She says, thank you so much. This has been incredibly helpful and timely in my journey, particularly with the advice on the pressure in MLD methods, as I've always been told the opposite. I'm meeting Mr. Sinclair Gore at OLP on Tuesday for my first consult and scan in the hope that I may be suitable for LVA. Secondarily,
Fantastic.
on lower limbs, abdomen, and groin following treatment for cervical cancer in 2018.
Fantastic.
Wonderful.
We'll look forward to meeting you, or Sinclair will look forward to meeting you, and no doubt you'll have an ICG scan, and we'll know from the answer from that and the rest of the clinical assessment, hopefully you'll be suitable for some kind of reconstruction.
I guess we've saved Dr. Sinclair an explanation.
He'll show the same videos, I'm sure.
Yes, exactly. So this second comment in the chat is, first, thank you for sharing this information with us. I was diagnosed 26 years ago. I am primary. Have you ever seen lymphedema return after surgery?
Good question. So what we say to our patients is where you get to after a year post-surgery tends to be where you stay. So if we don't see any response and the lymphedema continues to get a little bit worse, a little bit worse, a little bit worse, then that is going to be the pattern of what's happening. If we see the lymphedema get a little bit better and then stabilize, then our longer term follow-up from patients who we've operated on many years ago says that roughly where you get to at a year, it tends to stabilize in the longer term for that. And that, you know, that's for the reconstructive options. The liposuction we've only been doing for a couple of years now, but Professor Brawson's data shows that that's very stable. He's got follow-up up to 25 years now. And
Wow.
as long as you carry on wearing your compression, then your limb actually stays the same or gets smaller compared to the other side, because the other side puts on a little bit of weight, as we generally put on a bit of weight as we get older, whereas the operated side doesn't have the capacity to put that weight on.
Okay, back to the Q&A. I believe that patients who have gone through surgery still have to wear compression stockings. Why? What type of stocking would be needed?
So again, this depends very much on the patient and the stage of their lymphedema when they have their reconstructive surgery. I'm sort of assuming this is in relation to reconstructive surgery, because everyone who has liposuction has to wear compression, because we're not reconstructing the lymphatics, we're not making the system work better. So in terms of reconstructive surgery, what we found was that if you start off with a smaller, if you've got, say, one leg affected and there's a smaller differential between the two legs, then you're much more likely to be able to get out of compression stockings. If you've got, let's say, a 20% plus difference between the two legs, then you're really, really unlikely to be able to get out of stockings. So the point of doing the surgery then is to try and bring the volume down a little bit, most importantly, stabilize it for the rest of your life. And also it helps reduce the risk of getting complications such as infection and cellulitis. In terms of what the stockings would be, they're very standard, just the same as you would get prescribed from your lymphedema practitioner if you hadn't had surgery.
Okay. Would you recommend wearing custom flat knit garments right away or after a period of time when the incision has healed? Thanks.
So this varies between type of reconstructive surgery. So after the incisions are healed, absolutely, for the LVA and for lymph node transfer. For liposuction, we try and get the patients as soon as possible into the custom flat knit garments. And in actual fact, the incisions for liposuction, they're about 5 millimeters or so. And we don't stitch those up at all. We leave those to heal. It allows any blood or fluid that accumulates after the operation to come out, and they heal themselves really nicely within sort of 2 to 3 weeks anyway. And so it's much better to leave them and not stitch them up. And so for those patients, they're getting into those custom flat knit garments pretty much as soon as we possibly can.
It always looks so tough to me when I see patients recovering with the incisions, and then the thought of putting on a flat knit, sliding it over. Just
it is, and they're very brave. They're very brave.
Lots about legs and arms, but what about surgical options for genital edema? Thank you.
So good question. In limited time, I couldn't really cover that. The surgical options for genital lymphedema really are similar to for legs and arms. LVA is probably the operation of choice, but again, only if the lymphatics are working. And it really depends on exactly what's the route of the fluid getting into the genital area. So quite often there's overspill from the legs into the genital area. And so by treating the legs, you're reducing the amount of overspill into that area and you reduce the swelling there. Sometimes we do very, very high incisions to try to deal with the lymphedema in the genital area very directly. And that, again, it depends very much on personalized assessment and personalized Icg lymphography to determine what's the best option.
And that's for both men and women.
Men and women, yeah.
Thank you so much for this informative talk. I so appreciate your time.
That's an easy one to answer, no problem.
Listening to your point about pressure and massage, is gentle MLD massage a waste of time?
I think so, yeah, absolutely. And so the key is to get enough pressure to move the fluid through a tube that has a small diameter. So if you have dermal backflow and the fluid is in those tiny little capillaries, if we imagine that the normal lymphatics are sort of this big, those tiny little capillaries are this big. And what we know from basic physics and fluid dynamics is to move a fluid across along a tube with a very narrow diameter, you need a much higher pressure than to move a fluid along a tube with a big diameter. And because for most patients with lymphedema, there's failure or blockage in those main lymphatic channels, then you need much higher pressure. And again, this is one of the things that our patients really love about having their Icg lymphography is we can demonstrate this to them live in the clinic and they can see what the effect of their stroking or brushing versus pressing hard and pushing the fluid is. So that's another really good reason to have Icg lymphography, to really understand your own lymphatics and the effect of the treatments on those.
I was going to ask you if there was a publication on that, because I know there's one for pumps, but maybe I can go back with Dr. Aldrich and ask her if they've ever done anything on MLD, because I'm not aware.
So there's a therapist called Dr. Belgrado in Belgium who's done a lot of research on this and on the closing pressures of the various lymphatics and what have you, and how much pressure you can exert with a thumb, basically to demonstrate that if you press as hard as you can't really damage the lymphatics, which was the theory behind you have to press very lightly before, was that, oh, they're very delicate, they're going to get damaged. But he's shown that that's really not true at all.
Now I have an idea to have a speaker on imaging.
Yeah.
That would be very interesting.
It's a good topic.
Yeah, definitely. The next comment is, thank you so much. We have, well, you can see it. Thank you so much. We've not been able to locate one. And thank you for Mrs. Sanaris. Next one, can you self-massage? Can it be simple?
It's very simple. It's just press hard. You can certainly self-massage. So you can, the most important thing is you're going always from the end of the limb back up towards the center of the body. So you're going from wrist towards shoulder, or you're going from ankle towards hip. And if you're going in that direction and you're pressing pretty hard, make sure you've got some moisturizer on your hands to lubricate things, otherwise the skin will get irritated. But yeah, press hard, and that will definitely move fluid.
In the US, we always have to mention our disclaimer that these are the opinions of Dr. Furniss, LLP, my opinions, but it's not necessarily medical advice. I am not a medical professional. So always, if you have questions about your personal situation, always go back to your certified lymphedema therapist and your own doctor for advice to confirm. This is just general guidance for the topic of discussion as well.
Thank you.
Let me answer that one. And would the hard pressing have any issues with the blood clot? Oh.
Not that I can think of. I'm not quite sure whether the questioner has got a blood clot and is worried about dislodging it, or whether worried about forming a blood clot by pressing hard. It would be very difficult to form a blood clot by that. The deep veins where things like deep vein thrombosis happen, they are down deep inside the limb underneath that fascial layer, and it's hard to imagine them getting damaged by pressing hard.
Yeah. There are documented contraindications to MLD or manual lymphatic drainage. So again, like cardiac edema and other situations. So if you suspect that you have a blood clot or a DVT, your best bet would be to go to the emergency room or to your doctor, because that is potentially a life-threatening situation.
Absolutely.
Which pumps would you recommend for a home setting in the UK? Does it work for mild primary lymphedema? Thank you.
So to answer the second question first, yes, I think pumps are really good. They do work very well. They can work for primary or secondary lymphedema. In terms of which pumps we recommend, there are various companies who produce different pumps. We're not affiliated with any of them. What I would say is the good ones will offer you a trial. So they'll offer you, for example, a 2-week trial where you can take the pump home, you can use it every night, and you can decide whether this is good for you and whether it works for you or not before you buy it. And I would strongly recommend that you did that before you purchase them, because they're not cheap. We've had patients who've used pumps from Haddenham, and they've used Lymphopress, which I think is available in the States as well as in the UK. These have worked very well. So I think the pumps are quite similar in what they do, and it's a case of getting one that works for you.
Okay, the next one is, thanks for this presentation. I'm from Canada. Would you know if surgeries for lymphedema are available in Canada?
I don't know, unfortunately. We have treated a patient from Canada who came over to us from Quebec, I think, if I remember rightly. And they had leg lymphedema, and they hadn't been able to find a local surgeon. That was probably about 2 years ago, so I don't know whether the situation's changed.
Okay. Next one is a thank you, and she hopes my lunch is delicious. I hope so. I actually shouldn't complain because my husband does a lot of cooking, so I guess I'm fortunate in that respect. And the last one was from the previous commenter. No, I do not have a blood clot, but when they gave me a pump, that was hard, and they stated that it would cause a blood clot.
Yeah, I can't imagine how that would happen, but it might be worth discussing with your local professional team about what their thoughts on that are, whether they have any evidence that that is the case. Quite often people in lymphedema will say things without any evidence, and it's always important to be critical of what they're saying and really think about it and get them to think about it as well. I think that's
important to self-advocate. Advocate
Yeah.
for the situation. Get a second opinion, a third opinion. It never hurts. Don't have to worry about hurting someone's feelings.
Absolutely.
So I think that's it. We
I think
are
that
almost
there's
15
one more.
past the hour.
There's one more in the chat about papers
Okay.
from Belgium. I'll need to look those up, but I can I can send those to you, Veronica, and you could maybe pass them on.
Okay. Thank you both for your time. Oh, I did have one last one from the email that came in.
Mm-hmm.
If I can't find it very quickly, then we will end. Oh, I believe it was the person that already commented. So we're good to go.
Fantastic.
Thank you for your time.
Thank you very much, Veronica. It's a pleasure, as always.
I'm so glad you healed well and you recovered and were able to present to us. Looking forward to hearing more from you and more great things that you're doing in the future.
Great.
You're always welcome back to the Lymphie Strong community. Thanks so much.
Thank you. Thanks.
Have a
Bye,
good one.
everyone. Bye-bye.
Bye-bye.